Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Thanks for your company. In this broadcast, we're going to take a look at anxiety. And our panel today, we have Dr. Nick De Felice and Dr. Jeff Hook, who join Dr. Olga Ward. And they take a look at 3 different scenarios where a patient exhibits anxious behaviour. They discuss the level of anxiety and the best way to manage the patient in that scenario.
Well, Nick and Jeff, welcome to the program.
Thank you. Thank you.
I think in general practice, anxiety is quite a common adjunct to what the patients come in with. And certainly we see a lot of anxiety-provoking consultations. But sometimes it does become quite pathological. And one of the things GPs need some help with sometimes, I think, is working out what's pathological and also how to support the extremely anxious normal individual. So perhaps we'll look at a scenario and then come back and ask you for your thoughts.
Sure.
Mrs. Walton, come in, please. Take a chair.
Thanks, Doctor.
No, I haven't seen you for a long time.
No.
What's been happening?
Well, a few things. I feel very short of breath a lot, and I just feel, I don't know, I just don't feel myself. And I've had a bit of bleeding when I go to the toilet, and it's just not getting any better. And I just think, I went onto the internet and I looked up some of my symptoms, and I just think I need some tests. I don't feel myself.
How long has this been for?
3 months.
And is there any reason for that?
Well, that's why, no, I can't see that there would be a reason. I think there must be something wrong.
And you said you'd looked up Dr. Google.
And also my auntie, she was a nurse, and she said get tests done. I think I should get some tests done, some blood tests done. Maybe I've got cancer. I hope I haven't, because I lost my father to cancer a couple of years ago. So, you know, we've got to nip it in the bud, I think.
Right. What sort of cancer did your father have?
He had liver cancer, but he drank a lot, so I don't drink.
And are there any other members of your family that have had cancers?
No.
Is there anything, you said nothing's happening in your life, there's nothing new?
No.
Okay. All right.
I think I might have cancer. I don't like that idea.
Okay. Well, I think that the thing that
I've got a pain in my back as well. I didn't know whether that was associated with the... And I just, as I said, sometimes I just feel like I can't get enough breath, you know,
What do you do when that happens?
I make a cup of tea. I mean, I'm still, you know, my business is busy, so, you know, I try and just not think about it too much, but then I get worried that I'm not dealing with it.
Now, this bleeding, what sort of bleeding is it from your backside?
Oh, it's just a little bit of red blood on the toilet paper yeah.
What's your biggest worry? You said you're worried about cancer.
Oh, well, I guess just watching someone go through that is pretty awful. You know, the sort of effects of cancer and the deterioration of your...
Mm-hmm.
It's pretty intense, you know.
Okay, and this shortness of breath that you have, this feeling of pressure, you said.
Yeah.
Tell me more about that.
It just feels like I can't get enough air in my lungs. I don't have asthma or anything.
And that's at night?
It's when I'm under stress. Like I feel it now because I'm starting to talk about my symptoms. But, you know, I just think I'd probably feel better if I have tests done and stuff like that, you know.
Well, that's quite a difficult scenario with a patient with a normal kind of general practice presentation, but an enormous amount of anxiety attached to it, probably some somatic symptoms which we need to sort out, and sometimes terribly difficult for the GP to just keep the patient on track to get some useful history as distinct from some hysteria which comes along with it. How do you deal with that sort of patient?
In medicine, we sort of like to keep the questions open, etc. But there are some circumstances where the GP, the doctor, has to take control of the interview and focus the patient on what is relevant for them. So in this sort of circumstance, I would tend to try to ask more closed questions, because the patient needs to be guided as to the information that might help you sort things out, because otherwise they'll go from topic to topic or symptom to symptom without really leaving you in the end of the interview with a clear idea as to what's going on.
How do you sort out what's kind of a psychologically based somatic symptom like cramps or back pain or tightness or tiredness, and what's actually might be related to physical pathology?
I don't think there's any shortcut to that assessment. I think the GP has to use all of their skill in eliciting the sort of physical symptoms that might point to a pathology. And I think in these sort of circumstances, you sometimes also need to satisfy your need to do investigations or do examination that actually might help you to sort of distinguish things. But on the other hand, you also perhaps need to specifically ask questions that point you to the sort of symptoms that highlight anxiety disorders, and that they might be the relevant feature. So in this person, certainly anxiety could be complicating their physical presentation, but also the physical symptoms could be symptomatic of anxiety, and you really need to ask about the anxiety disorders.
You still might have some value from some psychological techniques in even someone with a physical disorder in calming or your breathing techniques and things like that, relaxation strategies that still might be quite useful for someone with a physical disorder, if not a specific anxiety.
So even if they've got a physical problem, they still need to get their anxiety under control as well,
And that might help in the reduction of muscle spasming or something else which might assist in reducing the pain.
Tummy cramps.
And I think too, when the doctor gives the impression to the patient, to an anxious patient, that they know what they're doing, they know what they're looking for, you then lay your hands on them, you examine them. There's a strong power in that can actually help allay the anxiety as well, That's right. So I don't think GPs sometimes appreciate the value of just being the doctor in charge of things, and it's not always something that we promote, but you should use your position to try to help that anxious patient, And then if you want to specifically sort of drill down to what sort of anxiety disorders you might be looking for, I guess that there's a generalised anxiety disorder, there's panic disorder, there are various phobias, and there's social anxiety disorder. They're the sort of areas to sort of hone in on. And so to ask about generalised anxiety disorder, I don't know how you do it, Jeff, but I ask people, are you a good worrier? Are you a worrier? Do you do that really well? Are you a first-class worrier? And people who are good worriers, they'll say, "Oh yeah, I'm really good at that, Doc."
Exactly.
And then I'll generally ask, so do those symptoms? Does that worry ever cause any physical symptoms for you? Like, does it disturb your sleep? Does it make you tense? Does it make you shaky? Does it cause your gut to be upset, etc.?
And it may raise issues, I suppose, about some personality types, maybe people who strive for high standards or have that bit of perfectionism in there, or things like pleasing other people. Those sorts of things come through often as well in being anxious and worrying about their effect on others.
So that's how I'd ask for about a generalised anxiety disorder. Then when you're looking at panic disorder, I would usually ask, do your symptoms get to the point where you're panicking with it? Have you had a panic attack? And when patients say to me, "So what's a panic attack?" you then know that they haven't had a panic attack, don't you?
They usually know.
They usually know. And they're able then to, you then elicit the sort of psychological symptoms and the physical symptoms that are associated with that,
I guess the other thing that we see in general practice quite often is patients who've maybe had an injury and they get into this kind of cycle where almost the fear of pain stops them from doing anything, and they become incredibly wound up and tight and start kind of flitting from subject to subject and symptom to symptom, and you can't quite pin it down.
In that circumstance, we're not actually looking at an anxiety disorder, we're looking at more on the somatoform spectrum. So they will have anxiety about physical symptoms, and of course that anxiety can actually aggravate their symptoms. I guess in somatoform disorders we think that people's internal distress is being expressed through somatic symptoms, which is something of the scenario that you presented here. You know, when I read that scenario and I saw that scenario, I thought, this is really along the line of somatic symptoms, you know, as a presentation of anxiety rather than just a pure anxiety disorder. Though this person could have an anxiety disorder as well.
Yep.
They may not, but they may just be a wound up normal person.
They may be, yeah.
When does it become abnormal?
Well, you know, our diagnostic manual talks about when there is, in all of the diagnostic criteria, it always adds these symptoms cause functional impairment, they cause social or occupational impairment. So when that happens,
not coping, perhaps.
Yeah, we tend to think of that as that's when it becomes abnormal. You know, I guess the fact that patients are seeing you about it tends to indicate that they've reached the point where they're distressed enough about it to identify that, well, you know, is there a functional impairment that goes with it? You know,
Assuming that there's no underlying physical thing.
Sure.
When they coexist, how do you decide what's the kind of level of psychological impairment that they're experiencing?
That is a very difficult question. Over to you, Jeffy.
I still think you need to treat what's presenting. If you've got, you know, an anxiety component to that, then I think that needs to be treated in some way, be it in dealing with our physiological symptoms, but also maybe dealing with some of our cognitions and our thinking, and maybe there's a role in there for some cognitive behavioural therapy, challenging, maybe slowing down the thought process, bringing some realistic knowledge about maybe the disorder or problem into the picture would be very helpful, I think.
And sometimes, Jeff, the problem that you've got in the first place is that the person is so convinced about the presence of a physical disorder or a physical problem, almost the first step you have to take is in educating the patient and trying to show them the link between the body and the mind. I mean, in our society, we divide those two. There are lots of cultures where there isn't that division in the sort of general thinking about, you know, mind and body, that duality, you know. So I often use the example of blushing. I say to people, if I try to explain this concept, I say, well, look, you know, when you blush, that's an emotion that causes a measurable physical change. Our body and our mind is the one. And so in the same way, emotions can have some, you know, physical manifestations.
The other thing, just going back to our cognitive behavioural therapy, the other thing people talk about is prediction and jumping to conclusions, and fortune telling is one of the distortions that we talk about. And so that could be applied in these circumstances. People are jumping 2 or 3 steps ahead and coming up with a number that may or may not pan out. So it's some challenging in a simple way.
Okay, so even just using the term like, hey, listen, your fortune telling here
absolutely
might actually help to allay some of that. How would you treat this in a general practice setting where you've got maybe a 15-minute appointment? You can see the patient possibly once a week. Is this something where you would actually need to engage with the local mental health team? Is this something that maybe a GP could help the patient to manage on their own?
There is a lot to sort out in that first interview, and I suspect
Don't we know it?
most GPs would, I suspect, get the person off to do whatever simple test you think might reassure them, as long as they're not too distressing or not too sort of encouraging of the idea that that the patient's sick.
Yes.
You know, get them back, and then
Yep.
an education session might be needed, and then at that session you're often talking about treatment. And I guess for me, I think of treatment in terms of physical treatments, like, you know, pharmacological treatments, psychological treatments, and then behavioural treatments that might be necessary.
Well, no,
So
this doesn't suggest to me pharmacology.
no, it doesn't suggest
To
that
you
to me.
either.
Yeah.
So
Yeah.
what would you
So
do?
some simple techniques, maybe if the person's still quite anxious, some simple breathing techniques might be useful. Simple relaxation strategies might be useful. So breathing in through your nose for 3 seconds and out through your mouth for 4 to 6 seconds, a bit longer. Making a straw with your mouth so that you slow the rate of breathing. And the other aim is to keep your chest still, diaphragm breathe.
Quite a lot of patients say to me, "Oh, people have told me to relax my muscles and I don't know how to do it." They're always tense.
Yeah.
Do you have anything that goes along with the breathing that you help them
Just
to
a
do?
quick technique I use is what I call a body check, where I just go from head to toe through the major muscle groups. So I might say forehead, jaw, you know, just shoulders, just focusing, just checking what position they're in, whether there's any tension, just trying to get them to go through each
So what do you
muscle
do
group.
with them, Jeff? Do you actually sort of say, okay, squeeze your jaw, or, you know, what do
You
you
can do a bit of that tension and then relaxing and letting go. That works
Yeah.
quite well. Or you can just get them to focus on it and just see, is there any tension at the moment?
I see.
Are you holding your jaw? Because people actually hold tension in their feet or hands and they're not even aware of it half the time, and that's building up that anxiety and breathing.
I can tell you a tip that's actually not useful. I prescribe relaxation techniques and I tell them to get a tape, and it doesn't actually very often work, but I still do it. I don't know. You know, that is, I tell people, look, you know, it's like a pill. Instead of giving you a script for a tablet 3 times a day or twice a day, here's a script for a relaxation technique a couple of times a day. And I mean, I wish I could sort of tell you that I had more success, but I
The
still
other
sort
way
of
to
find
look at
myself
it is,
doing it.
with a lot of these sort of people, is when do you sit down and put your feet up?
Okay, yeah.
And they don't. Just what's the life balance here? What time do you take to sit and relax, or even just do something pretty easy? What
Pretty
do you
easy,
do?
or just something that they enjoy?
Reading even, or something simple,
Yeah.
you know, where you're not actually running around or tensed up.
Well, see, that would be the issue in this person, in this scenario. What's happened now that's led to them having these symptoms now, these concerns now? I mean, as you say, it could be some physical symptom that they're now focusing all their anxiety upon,
Yeah.
or it could be that there's something else happening in their lives that gets expressed through their body, and you need to
Sort of
know
triggering it in
their
a sense, yeah.
circumstances. I mean, GPs are lucky because, you know, especially rural GPs, they'll know a lot about the circumstances of their patients and families.
A bit more on the
Yeah.
I've always had that impression that
We
they
still
do.
can't make it rain. We are
Okay,
trying.
Yeah, there are those things that are even beyond the control of the GP.
Well, let's have a look at a different situation in the same general practice where the patient is developing some of the other symptoms that you guys have touched on with some more features of an anxiety disorder rather than an anxious patient, and see where that goes.
Mrs. Walton, come in.
Hello.
Good morning.
Hi.
You're Rebecca.
Yes.
Yeah, how do you do?
Good. Now you
Please.
all right, Mum?
Yes, I'm fine.
Okay, I'll be in the waiting room.
You're not coming in with her?
No.
Okay.
No.
Well, don't
I'll
go
be
anywhere. I
won't.
won't be long.
I won't.
Okay.
Okay.
Come and sit down.
Thank you.
Now, good morning.
Good morning.
Haven't seen you for well over a year.
Yes, that's right.
What's been happening?
Oh, well, look, I'm just feeling, I'm just feeling, just not feeling great. I'm just feeling, I've got aches and pains in my legs. My big toe is really throbbing most of the time. I've got a pain in my back. And I feel short of breath. And, you know, it's nothing I can't manage, but my children wanted me to come in and see you and just, you know, talk about a thing, you know, things that have been going on.
How long has it been as bad as this?
Oh, it's just been accumulating over the last year or so.
Well, what do you think is the matter?
Oh, well, what isn't the matter, really? I mean, you know, my life's been really topsy-turvy over the last year or so, and I've had a lot of disappointments, you know?
I notice you're not in the shop anymore.
No, well, no, but the shop's closed because my husband and I have split up, and he didn't want me to be involved in the business anymore because it's too complicated in terms of, you know, a personal relationship with him, and we're not on speaking terms. So I just have to get on with my own life, don't I? You know, these things happen in life, don't they? And you just have to get on with it. And but I really am short of breath. That's a worry. I think I might have asthma or something like that because there is onset sort of old age asthma or something, isn't it?
Okay, tell me about the shortness of breath.
Oh, it's just like, I don't seem to be able to get enough air. You know, like even if I think I'm pretty sure I probably have asthma or something like that.
And what makes it better?
Nothing.
And is it any worse when you go out in cold
Yes,
weather?
it can be worse when I go out, especially if I go out to the supermarket. I don't go to the supermarket anymore.
Why not?
Well, because I don't feel comfortable in the supermarket. I can order things online. I've started to do that now.
Okay, so if you go to the supermarket, you feel very anxious.
Yes.
Is there anywhere else that you go where you feel anxious?
I don't like going out much anymore. It's better at home. I feel more in control at home.
Okay. So you're in the supermarket. What parts of the supermarket make you feel really anxious?
I don't know, the whole idea of the supermarket, the lights and the people at the checkout, you know, they're always busy, and sometimes I think people are watching. I mean, I just it's all right. It's just a stage I'm going through, I think.
Okay, so you feel very anxious, and when you
I've
get...
got a pain in my foot right now, actually.
Okay,
it's
I'll have
really intense.
I'll have a look at that. But just tell me a bit more about, you feel very anxious, and when you get back home, do you still feel anxious?
Sometimes, if I put the television on really loudly, I feel better. I don't know why that is, but I just feel like there's someone there, and it's okay then.
So basically, when you're at home, you function, and when you're outside of the house, you don't function.
Well, I don't go out much because I've stopped driving.
Okay. Well, let me have a look at you now.
And so my daughter's still outside.
Do you want me to speak with your daughter?
Can she come in?
Yes, she could.
Okay. Thank you.
This patient looked considerably more anxious than the last one, or at least considerably more disabled by their anxiety than the last scenario that we saw. What points you specifically to this patient having a panic disorder or an anxiety disorder? Is this panic disorder?
I think it's very likely to be panic disorder, Olga. I think that the person has clear panic attacks where they're getting not just psychological symptoms of panic, where they have fear and often a sense of impending doom. You often ask people and they'll say that, or they think they're going to have a heart attack, or they're going to think
mind's going to go
terrible.
mad.
Yeah, they're going to go mad
racing.
or going to lose control or whatever. And then they've got the physical symptoms of it. So usually heart racing. People find it hard to take a deep enough breath. So
yes.
What I ask people is, you just can't take a breath, can you? And that's how they'll experience it. The stomach churning,
jelly legs,
shaky
all those
hands, sweaty palms.
Tick, tick,
exactly.
tick, tick.
Exactly.
Sounds like the
Not
typical
always
medical
all of them.
student before the
Sometimes
exams.
dizzy, sometimes dizzy or lightheaded even. That's a
and
fairly
of course,
common one.
I mean, at the more extreme cases, pins and needles of their fingers, toes around their mouth when they're
Extremities.
hyperventilating a lot.
Yep, that's right. Yeah.
Right, so this
And
then becomes you would actually label that as a panic disorder.
Well, they're having panic
They're
attacks.
having panic attack.
Strictly speaking, a person with a panic attack is someone who then fears that they might have a further panic attack. A panic disorder is someone who fears that they're going to have a further panic attack. So then they become preoccupied about having a panic attack, and then that's, strictly speaking, a panic disorder. But I think most people would say when they're having panic attacks like this, they've generally got a panic disorder.
Yeah. Now, is this the sort of thing that then leads on to the patient that I guess you'd label almost as agoraphobic, the people who just won't go out in case something happens?
Precisely.
Well, as Nick said, it's that fear of having a panic in the place they maybe had the last panic, and therefore I won't go there. Or if I avoid that place, then maybe I won't get another panic attack.
Yeah.
And then they have one and they have to avoid a lot more places.
Correct.
Yeah. It's actually where the person fears they can't escape from it. So in the city, they'll be in the queue at the shopping centre and they just can't stay there. They've got to get out.
Leave their
even
trolley.
if they can actually get into the
Yeah,
shopping
yes,
centre
yeah.
in the first place. But
Well, correct. Yeah, correct. That's
maybe same in country shopping centres.
Yeah.
Well, I'm thinking about the patient who maybe lives quite a long way out of town
Yeah.
and can't bring themselves to get in the car and
Get in
drive
in the
into
car.
town, which is a
Right, that's
bit
the
of
other
a problem
main-
when you need bread and milk and
And
Yeah.
things start to close in after a
Back
while,
then,
isn't it? You
yeah.
can't go to your
Yeah.
letterbox, you can't go outside
Yeah.
the front door, and
Yeah, yeah.
so it goes. Yeah.
So, out of this huge chaotic mess of symptoms, what are the things that you pin down with the patients that will give you the best clues that you need to intervene here?
Well, I think just the symptoms itself. I mean, I've seen people who tolerate depressive symptoms for a decade. At the first sign of a panic attack, they're in straight away. And so people will often present with those symptoms, though the tricky bit is that you can actually miss it and think the person might be having a medical condition. So typically, people sort of like are investigated for
Tests.
heart attacks, or they've had coronary angiographies before someone clicks that, oh gee, this might be a panic disorder,
Or both?
Or
Of
it
course,
could be
because
both.
Yeah.
by the
could be.
time you shot
Could
some
be
dye
both.
up somebody's arteries and they're over 60, they're quite likely to have something else as
Sure,
well.
true.
It becomes more than a red
Yeah,
herring, doesn't
yeah.
it?
You've then got some of the things like avoidance, the not
Yeah,
coping,
yeah.
functional side of things, not working, not
Yeah.
being able to do your normal day-to-day routines,
Yeah.
socialising, very
Difficulties in
restricted.
socialising, yeah.
What sort of strategies would you use, say, as a GP to kind of get a handle on this quickly and give the patient some hope that it can be controlled?
Yeah. Well, I mean, I guess that, again, there's pharmacological strategies, there's psychological strategies, there's behavioural strategies as well, and also environmental strategies, looking at the things that might be sort of leading to those matters, So, I mean, from the pharmacological point of view, although it's tempting to use benzodiazepines, and they are probably the thing that will most quickly get the anxiety under control, the main pharmacological treatment, the mainstay of such treatment is antidepressant medication. Even though they're called antidepressants, they're actually good anti-anxiety agents. So that's how you start the treatment, but very often, with the modern antidepressants, the SSRIs, the SNRIs, people will have an increase of anxiety to start off with. So often in that circumstance, you'll need to use something else to try to help manage their anxiety, like a benzo, or even a Phenergan, or even a major tranquilizer if you need to.
Which benzo would you use and why?
Well, it depends on what you're used to. I would generally use something like alprazolam or lorazepam. The reason I'd use it is because I'd want the patient to understand that I'm going to be using it short term, and I want to titrate the dose. So if you tried to use, let's say, diazepam, it's a long-acting drug, harder to titrate against the person's symptoms. So alprazolam, say 0.5 milligrams twice a day or 3 times a day, or lorazepam 0.5, 1 milligram 2 or 3 times a day might be just enough to get their symptoms under control, whilst hopefully the antidepressant works, and hopefully you can start instituting
Okay, so do you
psychological
actually
treatments.
give them a time frame and say you're going to be taking this for only the first 3 or 4 weeks, so that they don't have an expectation of continuing it?
Yeah, I try to do that.
Does it work?
Well, it depends on how successfully the panic disorder is treated with the other treatment strategies I've got. I find that if people respond to the antidepressant and they respond to the psychological treatments that are used, they then find it quite easy to come off the benzodiazepines. It's when they don't respond that you're really then having more trouble,
And there's a huge amount of controversy about alprazolam
Yeah.
in the medical press, and I think in the general press as well. And it's got an enormous street value for recreational purposes. So
Yeah.
are there any kind of controls on that we should be aware of?
I think you need to be aware of how much you're giving your patients, how much you're prescribing for them. That's the first thing to be aware of. And I think in country towns, rural towns, you've got a better connection with pharmacies in the town, so you might be able to sort of manage that a little bit better. Or even if you write on the script the frequency at which you want the medication
So
given.
next prescription, not before the 20th
21
of next
days,
month or something.
or whatever, you might do in that regard. So that's one thing you need to do. I think we have in our consulting rooms with us, we have our society with us. So we don't use drugs just simply on their pharmacological action. We have society in there telling us that it's okay to use clonazepam for epilepsy, and to use it indefinitely for epilepsy, but it seems not to be okay to use it for, let's say, an anxiety disorder. So we understand
even
that,
though they're both chronic disorders.
we understand that society's in the room with us. So if we just look at the pharmacological action, I mean, the benzodiazepines are drugs that have got very little in the way of side effects, except for excessive sedation if there's too much used of it. They're quite good drugs, but we have to know the limits. We've got to be careful and warn people about dependency, and then manage that risk. And there might be some patients where you're a little less inclined to do that, Olga. Like if you know the person is a somewhat dependent person, or they've had problems with alcohol abuse before, you just want to be a little bit more tough on how much you're
Time
prescribing
limited,
and what you're doing. Yeah.
And in terms of SSRIs, SNRIs,
Yeah.
are there any that are particularly better anxiolytics than others?
Some of the companies would like us to think so, but I think that pretty much when it comes down to it, they all are about the same. Some are a little bit more likely to lead to anxiety when you start them. So, for example, paroxetine, I think, would probably be a bit more likely to lead to anxiety, or the SNRIs, because they've got a noradrenaline effect with it too. So they're more likely to lead to anxiety. But on the other hand, I found them to be somewhat more effective too. And in fact, paroxetine is the SSRI that was first introduced or first recognised in terms of use in panic disorder. So, so it's actually quite a good agent in that disorder. It's just that you've got to be careful with starting it.
What's a realistic timescale for their symptoms to at least be initially under control?
Well, you really want to try to get it controlled very quickly. So if you're going to use a benzodiazepine, hopefully their symptoms will be significantly better within the first few days. And that really helps you with regard to engaging the patient. And I hope that you don't just talk about medication, you also talk about psychological treatment at the same breath, because otherwise they'll get the idea that medication is the way to go. And you just don't want that idea.
So once their brain's actually in a state where they can accept some psychological interventions, what sort of things would you go through, Jeff, maybe for a GP to introduce, and what sort of extra strategies would you use as a therapist?
I think the first one with the panic symptoms again is breathing control and breathing techniques to reduce hyperventilation. So the similar technique I mentioned a bit earlier would be good, I think. The other thing you want to maybe introduce a little bit of cognitive therapy, or at least in order getting someone else to do that would want to be happening in terms of challenging their thinking about going out, or the issues about going out from the home. But probably the mainstay is some behaviour therapy or exposure therapy, where you would look at trying to move the person out, say from the home if that's the case, into the community a bit more in a desensitisation way. So I'd be creating a hierarchy with the person of simple steps, in a graded way to get to the front gate, to the letterbox, and then further out, maybe with a friend in the first instance, and then gently on their own, grading the process up. The important point is that they will experience anxiety in each of those tasks, and the most important part is to select the right level of task, and the patient needs to stay in that situation till the anxiety reduces, so that you're not left with doing a step where your anxiety's high and you have to escape out of it and it becomes a noxious experience.
How often do you involve families with this sort of treatment?
If it's possible, I think, depending on the severity and whether the patient could can do some of the steps themselves, I think it's a great idea to involve them just to get the ball rolling, and maybe also as an encouragement person or even a coach sort of person as well. I find that very useful, and it keeps them honest in a sense as well. Have you been doing your exposure tasks? Yeah. The other thing we do quite a bit, which I don't know if a GP might do, but you can actually induce some symptoms of panic, in the sense that you could maybe get some lightheadedness or some dizziness happening, or some jelly legs happening. Symptoms that the patient might have by deliberately hyperventilating in the room with you. I tend to run someone up and down a staircase and then get them into a room after that. Immediately after, I get them to hyperventilate for a minute, and then I get them to sit back. And now I'd say, right, I want you to use all the techniques we've covered, the breathing techniques, the relaxation strategies, the muscle body check, put them all into action now, and I time how long it takes them to bring that down. And I say, right, we're going to practice that several times, and you're going to try and get quicker at it. I want to know if it replicates some of the symptoms that you have, because the more it does, the better. And what we're showing is that the patient can induce the symptoms themselves and reduce the symptoms themselves, and it's not attached to an environmental factor which they've already thought it was.
And I quite like that idea of maybe getting them, I mean, there aren't that many two-storey buildings in Westonia, so they might have to go and do star jumps in the corridor or something.
Exactly.
But you know, associated it with a physical activity, so that, you know, the hyperventilation or the being puffed out doesn't particularly just associate with going to the shops. Or
and they're often surprised that the symptoms come very similar to what they've had. And so they start to make the connection that maybe it's not, it really is them doing this, and I can get this under control perhaps. The aim is not to make them into the panic range, it's to get into that 7 or 8 out of 10, let's say, but below panic, so that I want to keep that sense of control. And I want to reinforce it by bringing it down. I want the speed of bringing it down to increase each time.
Yeah, given that GPs often don't have a lot of resources, and that the mental health teams are often quite stretched or just not there, are there any other kinds of resources that you use with the patients that you've found useful or helpful and easy to get at?
I think there's online resources now that are probably quite good. There's quite a lot of CBT therapy online, which has shown some efficacy.
Which site do you direct people to?
I haven't directed them a lot, but I know the CRUFAD site, the Gavin Andrews site in Sydney is
Mood
good.
Gym is quite
Mood
good
Gym
as well. That's the ANU site.
So the clinical.
The other thing
presumably
I do
these
is,
are quite good for a lot of psychological things and not necessarily just for anxiety.
well, CRUFAD is more particularly for anxiety disorders, actually.
It moved a bit into depression, but it started in anxiety.
And the other book that I think is the Bible for panic disorder is a book called Living with It.
Yes.
Bev Osborne's book that
Bev
I...
Osborne's book, which I think is probably the self-help book that I've told people about more than anything else. It's a fabulous book. And once people see it, and they see it in writing, and they see it in a simple cartoon, they really gel with it.
I think the nice thing about it is particularly a lot of country patients who are a bit older, they've left school at year 10 or year 8 to work on the farm or to help mother with the other children, depending on how old they are. They don't have a lot of reading ability for these kind of concept self-help books, but this is just something that's full of little pictures and cartoons and things that make them laugh. And every time I've sent a patient and said, go and get this book out of the library, and it's out of the library a lot, they've come back and said, oh, I was on every single page of that.
Exactly, and that really sort of helps, helps them identify. It makes them think, oh my God, they know what I'm talking about.
And I'm not the only one with this problem. That's so common. The other thing I say with patients about you, Nick, is that maybe you're never going to get rid of panic. It's one of those things you might always have as someone gets migraines. It might crop up, 10 years down the track. So I'm trying to build in the idea that you shouldn't aim to get rid of it completely. And so, and therefore don't panic again if the symptoms start to come back. It's to be expected. Just use the techniques as usual, and you get through it as usual.
They're still going to work in 10 years' time.
Correct.
And in fact, a lot of patients do that. And if I've sort of seen a patient who's had a panic disorder previously, very often the history they'll give is they'll say, well, I still have panic attacks, but they don't bother me any longer.
Perfect.
I keep them under control.
Perfect. Yeah.
When they come, I breathe and I'm okay.
Yeah. Yeah, brilliant.
Well, let's look at a slightly different scenario yet again.
Mm-hmm.
This time, a patient with some anxiety symptoms that their family might interpret it as anxiety, but who has something completely different going on underneath.
Mrs. Walton, please come in. Yeah, just take a chair. Well, I haven't seen you for quite a while.
No,
How are you going?
I'm fine, thank you. I just need another prescription for my ulcer. I think you prescribed something starting with an S.
You've been on that medication for a long time, I see.
Yes,
And you're still getting symptoms, are you?
yes. Stomach.
And they haven't changed at all?
No.
The last time I think we looked at that was 3 years ago. I think probably we need to, or at least I need to organise for you to have another gastroscopy. You know,
Oh,
with the tube.
I don't want one of those.
Why not?
I don't like things going down my mouth.
But if things haven't got better, we need to really have a look and see what's happening.
Is there another way you can do it without having to put something down my mouth?
Not really. We can do some tests for the bug that causes the ulcers. You don't look very happy today.
I'm fine, thank you.
What's been happening to you?
Oh, I've had a problem. I have a cleaning lady that comes in once a week, and she's stealing from me.
Right.
So I've had to tell her to go. We had a bit of an argument, and I said that I didn't want her in the house anymore. My children said that they're very fond of her, but she steals. She's been taking money from me, and she takes food and toilet paper. That's the problem I've had this week. So she's gone, so that'll be good. She's gone.
Why does she take toilet paper?
Toilet paper's expensive. She steals money off me too. She takes money from my purse. She takes $15 from my purse every time she comes. $15. I count it out. I know how much money's in the purse before she comes, and when she's gone, $15 has gone. Now, I have said to my son and the rest of the family this is going on, and they don't believe me. I think she's been sent.
Why she's been sent?
Yes.
She's been sent to take $15 in toilet paper.
No, she's been sent from Satan. There's bad people out there, Doctor. You must see them. They must come in here.
What else is happening?
I get phone calls, strange phone calls. I don't know who they're from. They hang up. They hang up on me.
Well, this is quite a different scenario, and this is the sort of patient I think in general practice who is often brought in by a relative who's worried because they're querulous and they're anxious about everything, and they seem to be quite fearful. But actually, it sounds to me like there's a lot more going on.
The first thing that this person requires is an adequate assessment, because although anxiety seems to be the presentation, the reality is that it's psychosis that's the primary problem, and one needs to try to understand the psychotic symptoms that are present, which have been clearly elucidated in the history, generally from family members who'll tell you that mum or dad said this or said that about someone stealing things or breaking in. Yep. But that's not the end of it, because of course they could have something unusual like late onset schizophrenia, so paraphrenia. But very commonly people with dementia might present with similar sort of symptoms, though in that circumstance the history of cognitive decline, the history of increasing memory problems is something that if you alert the family to, if you ask the family about, they generally will recognise and identify, you know.
Yeah.
So that's the sort of differential diagnosis that you particularly want to have in mind. I mean, quite apart from, you know, organic things like brain tumours or other things that
Strokes.
or strokes
Common.
or other things that can happen.
With this kind of patient, if they turn up in your office on their own, you know, and they obviously this is usually a long-term patient in a general practice, and they come in for their blood pressure tablets, and the doctor goes, "And how are you going, Mrs. Smith?" Thinking, nice 5-minute consult. Yeah, I can catch up.
This
And
is
she
an easy
says,
one.
This is an easy one. And the silver chain lady is stealing my newspapers every morning, or you know, the next door neighbour's living in my roof space, or you know, there's some really odd things that they can come out with. And once you've, I guess, scraped your jaw off the floor, how do you get a handle on that without putting the patient offside and them thinking you're part of the enemy rather than somebody who's trying to help them?
I think, Olga, all you can do is ask direct questions, and you know, without sounding like you think that they're crazy or that they're going mad. So you know, so tell me, you know, why do you think the neighbours in your roof? What's happening with that? Like, how are they getting there? So you can ask in a way that's asking for more information, or what's happening with the silver chain lady? You know, when are they? What are they stealing? Why are they doing that? When did that start? So it's almost like a systemic inquiry about the various the concern that they might have. Hopefully, that will engage them enough to tell you what's going on. You then do need to ask more specific questions like, is there anything else that's unusual that's happening, or that seems to have been started recently? Are you worried about other people maybe wanting to hurt you?
Yep.
Are people talking about you? So they might sort of at that they might say, yeah, the neighbour, they're walking outside and they're speaking about me at night. So you'll be clued into auditory hallucinations that they might be experiencing. You know,
There's people looking in at my windows.
yeah,
when
those sort of
there
things.
aren't
You know,
really,
I mean,
they
the
hear
reality
something.
is, once you've elicited that they're psychotic, well, they're psychotic. It's then a matter of trying to understand what the other symptoms are that might point you to the diagnosis. This presentation tends for me to point to either a paranoid disorder or, let's say, something like dementia that you need to just, you know, go around a little bit more.
Do you just accept that this patient's sort of psychotic but vaguely functional, and kind of pussyfoot around it so that the whole world works around it, or can it actually be treated?
Yeah, that's
And
a really
will they
good
develop enough
question.
insight to swallow the tablets if you are going
That's
to
a
treat
fabulous,
it?
yeah, they are fabulous questions, you know, and I guess if I could say to you that we have fantastic antipsychotic drugs that have got no side effects and that work really effectively all the time, you really could make a strong case to say any time someone with a psychosis presents, you should intervene, even in an involuntary setting if they don't have insight. But I don't think that's the case, and I think that you want to try to work with the person, first of all, to say, okay, well, first question is, does this person have to be treated? And you know, that then becomes a question is, do they need involuntary treatment or not? And I think that that's something that you'll get more from family members than the person themselves. I think that they warrant a discussion with the person about treatment, and sometimes you have to work around the problem. You know, you might have to use the medication to help with their sleep or to help with their distress. Now, that is, you introduce the medication to deal with the problem that they present rather than the problem you perceive. So if you can do that, they can sometimes accept the treatment for, you know, perhaps you know, vicarious purposes. You know?
Yeah. Now this is a very socially disabling kind of disorder as much as anything. Jeff, is there anything that you in the psychological strategy area could offer for this patient?
I suppose it depends how focused the problem is. If it was more of a particular item or a more focused psychosis, then there might be some room to build some rapport and try and get that person to sort of encapsulate those thoughts about that and keep it to yourself, or have that discussion about just talking about it with me. And there's also even some room for some CBT in that area, but it would have to be fairly narrow, I think, to be able to deal with that.
Antipsychotic drugs, let me not mislead you, they can actually work really well for someone like this. Sometimes they do relieve the symptoms, so the person in due course says, "Gee, I don't know why I thought that," and they gain some insight. But even if that doesn't happen, often the drugs will reduce their paranoid drive so that they can contain the symptoms, let's say within the therapeutic relationship or whatever, with the doctor, rather than spreading it around, or going
Sacking
to the
the poor
police,
cleaning lady and going
Well,
to the
exactly.
police.
Yeah, if these things happen again, come and talk to me about it. and we can deal with it.
Prosecuting the poor neighbour who's living in their roof.
Yeah, but again, making sure that you try to keep that rapport going. If you can possibly do that, hopefully you won't get dragged into the psychosis as well. And then yes, supporting the family.
And supporting the family is quite a big one,
keeping
actually, because
them,
that'd be quite a stressor, and wouldn't be surprised to see that maybe bring someone else down in the family as well.
Yeah, true.
So certainly being aware to those people would be very important.
Almost certainly, particularly I think, in a country situation, it's often the unmarried or widowed daughter that ends up looking after the elderly person. And I, as a GP, tend to see this more in elderly people, but I don't know whether it's just that they're in the doctors more and they talk about it more, or whether does this start as a young person and just kind of remain undetected?
So let's say we're talking about a delusional disorder or schizophrenia. Of course, the typical age of onset is in late teenage or early adult years. When people develop psychosis or paraphrenia later in life, their personality tends to stay much more intact. So they tend to be able to contain the symptoms, and certainly if you explain it to them, and if major tranquilizers maybe don't fully work, but at least they control the paranoid drive, they are able to keep it to themselves a lot more, and you don't see the disintegration of their personality like you do in younger people.
And Jeff, when you said it often brings somebody else down in the family, do you mean that they kind of almost catch the psychosis, or do they just get depressed and pissed off with having to look after somebody who thinks everyone's out to get them?
I certainly think there's a strong, what we might call burden of care, if you like, and certainly depression, possibly anxiety, but certainly stress at least, I think is very common in that situation. Particularly, as you say, it often falls to one family member who picks up the load in that situation. So I think that would be very important to watch out for.
Nick, you mentioned antipsychotics, which might be effective in, I guess, pretty low doses in an elderly person who may be able to be helped to sleep. What's your antipsychotic of choice for this kind of setting?
So in this sort of circumstance, you want to try to use one of the more potent agents. So you'd be looking at something like olanzapine or risperidone or paliperidone. I think they're the ones that you'd usually want to start with. There are certainly others that are said to have less metabolic effects, but I think they're the ones that you generally use. Now, I guess what you use is
low dose, slow release?
Well, you start off with a low dose and you gradually build the dose up, particularly in the elderly. There is an increased risk of cardiovascular disease like stroke in people with elderly people with antipsychotic drugs, particularly in the dementia setting. I'm not sure whether that's been noted in the non-dementia patients, but certainly in dementia patients. So, there is that risk that you have to really discuss with patients, and there's even some sort of studies that look at maybe an increased mortality with the use of major tranquilizers, and that's not because they put on a lot of weight or all the other complications that can go with the major tranquilizers. But here in this scenario, we're talking about a fairly distressed person, an elderly person. You really want to try to get on with treatment, and knowing the side effects, knowing the risks, still it probably outweighs the
the quality of life.
The benefit they might get outweighs the risks.
How much improvement could you expect in, say, a patient like this in terms of their social functioning, assuming that the drug worked?
Oh, they'd get. I think that if the drug worked, they'd get back to their usual self, whether that be a usual isolatory self or a usually social self, but they'd.
But a much better level of function.
Yeah, I think so. Yeah.
I guess for GPs that's a heart sink, so it's great to think
Yeah.
that there's something that we can offer these patients and their families.
Yeah.
Before we leave this program, do you have any kind of final take-home points that you would like to make?
I think that treating anxiety disorders, we shouldn't. They've been labelled as the worried well, but anxiety disorders can be really incapacitating for people, and so it is important.
As well,
It really is important to identify them, to know what you're treating, and then certainly using pharmacological treatments, but also psychological treatments are really important.
And I think they're pretty well researched, some of the psychological techniques, and I really think they're one of the better lots for our patients that we see. I would expect, in most cases, a pretty good recovery.
Yeah, I think so.
Sounds great. There's hope for our patients and for us. Thank you very much for joining us.
Thank you.
And thanks to our panel, Dr. Nick DeFelice, Dr. Jeff Hook, and Dr. Olga Ward. Beyond Blue have recently been pushing to raise awareness and acceptance of anxiety in our community and to encourage those who suffer from anxiety to seek help. We spoke with Dr. Brian Greats from Beyond Blue about their campaign.
I've been expecting you. What? Don't tell me you don't recognise me.
A lot of what Beyond Blue does is actually raising awareness and knowledge around what mental health looks like and when you might be struggling and might have an issue. So for a lot of people, they did struggle 10 years ago to understand what depression looked like and was. And the same today with anxiety. So effectively, people aren't that great at understanding the symptoms of anxiety and what that might look like. And that's why we've really worked hard to actually show some video clips of what it might look. The Ben Mendelsohn ad talks about symptoms directly.
I'm the ill ease that you feel when you walk into a crowded room. You know, the hot and cold flushes that confuse you. I'm the one that raises the whip to your already racing heart.
For GPs, I think quite often there's a lot of information material that's really accessible for patients that they might be able to provide them to have a think about their symptoms. So Beyond Blue website has a whole lot of information resources that are really particularly suitable for patients. So it gives a sort of lay explanation of what anxiety looks like in its various forms and shapes. The other thing is it really gives you a lot of self-help strategies. So for patients who really have mild, moderate symptoms, for a lot of them it's really about some changes maybe to the lifestyle issues, whether it's physical activity, whether it's sleeping, whether it's alcohol use. And a lot of that's really just information for patients around how they might manage some mild, moderate symptoms. There's also, it's really useful to know that for anxiety in particular, it's quite amenable to online treatments, and over the next, or even now, but over the next 5 to 10 years, you'll see a whole lot of online cognitive behavioural treatments, which is quite an effective approach for anxiety that patients with, particularly mild, moderate symptoms would benefit by.
I am the tightening of your chest, the snowballing worries that feel like they might become an avalanche and can just bury you. I am the obsessive and I'm the compulsive. I'm the voice, the one. It's always questioning. And I am every single staring eye that watches you.
I think for us, we're really keen not to send the message out that anxiety is not normal, that effectively everyone will go through periods in time when they're anxious. When we're preparing for something important, having stress related to that and being anxious is perfectly normal. We're trying really hard to work towards for those people who have overwhelming anxiety on an ongoing basis and have associated symptoms around that, for them to recognise that there's a role there for the GP that's for them to provide information and support about where they might go and get help. And for a lot of it, it's not just the GP, it's actually the accessibility of information and treatments online.
So, now that we have become acquainted, what are you going to do about it?
And that's all the time we have in this program. Thanks again to all our guests for their time. And remember, if you'd like to review this program or any of our other programs, they're available on our website at ruralhealthwest.com.au. And while you're there, take a look at this special edition webcast that accompanies this program, which focuses on OCD. We're back again on the 2nd of July with a program looking at X-rays and imaging. In the meantime, thanks for joining us. I'm Jerry Gannon.